Absolutely. Thank you so much for the honor to be here with my colleagues and my mentors. So we're going to talk about radiation reduction in minimally invasive spine surgery. Throughout the day, you're going to see amazing things. Minimally invasive spine surgery, I think, is the future. It helps the patients out so much, right? Decreased blood loss of length of stay is decreased. But one thing that really comes out in all the literature is that our dependence on fluoroscopy, because we're not actually seeing the anatomy, is so much more. It can be up to 3 times more. And if we're using ionizing radiation, that could be potentially dangerous to our patients, to ourselves, and to our staff. And if you look at the data, it's actually quite scary. So if you look at orthopedic female surgeons, they have 4 times the risk of developing breast cancer as the general population. Okay, that's not something small. 4 times the risk. If you look at physicians that spend a lot of time in the cath lab, which is basically what us as spine surgeons are, 50% of us are going to develop cataracts at some point in our lives if we use ionizing radiation. So that's a lot, and that's something that we have to think about, and we have to think about very clearly. If you look at how much radiation in an MIST lift that you expose your hands and your eyes to, you're going to run out of your lifetime limit of ionizing radiation by about 15 years. Duke doesn't pay me enough for me to only work 15 years. I want to work more than 15 years. So we have to find a way to decrease that amount of radiation if we want to stay doing these surgeries for a reasonable amount of time. So if we look at what we were going to do, say, for an ideal navigation or imaging system, we want to have real-time imaging, right? We don't want to depend on a CT scan that was done 3 months ago or even 30 minutes ago, because maybe in those 30 minutes, something has changed with the anatomy. We don't want to fixate on the patient or the table. If we can avoid the use of pre-op CTs, that would be great. We want to be able to recalibrate easy, right? So if something goes wrong, somebody hits the reference array, I do some surgeries awake, the patient wakes up and starts moving, right? What are we going to do? We want to decrease radiation, and ideally, we want to actually be more efficient, because we know that the more time patients spend in the operating room, the more higher risk for infections and other complications. So if you look at what's currently available in terms of navigation and robotics, we see the following. They're cumbersome, they're complex. If you're going to bring this to the ASC, it's so big, so expensive, it's going to be very hard to bring in. And they're slow, right? I call it the slow bot. Not that I don't use a robot, I do use the robot sometimes, but it really is really slow. And so if you look at it, it can add up to half an hour of OR time, right? The more time we spend with the patients in the operating room, again, increased risk of infections, increased risk of complications. And if you look at the complications, these may be related to the amount of time that they're spending in the operating room. Now, if you look at, some people say, well, let's just do an intraoperative spin, right? We'll move the staff out of the room, I'll move out of the room, we'll just expose the patient to this. That's actually not benign as well. So if you look at, the average O-arm spin, just the underestimate is that comes to 500 chest x-rays, okay? So I think that is lost in the translation, right? We lose that data, right? So you're subjecting your patient to 500 x-rays every time you do 1 spin, right? If you do 2 or 3 spins, that's going to be 1,500 x-rays. And if there's some data that shows that you increase the risk about 1 to 2,000 patients will get the malignancy because of the fact that you did this intraoperative spin. So this is not something to scoff at, especially as physicians. Our first mantra is do no harm. 500 x-rays is some amount of harm. And then again, if you're not careful, you can have horrible things like this happen. So again, this is what we want for our ideal navigation system. Right now, and I have to make sure, just because technology is at one point now doesn't mean that it's not going to get there. Right now, navigation and robotics don't do any of those top 4 things, right? They may decrease radiation to the OR staff and to the physicians, and I'd still say that they are slowing us down. So what we've developed at Duke is this system, which is called computer-assisted navigation. It's a fluoroscopy-based system. It hooks on to your fluoroscope. There's no need to fixate onto the patient, and there's no setup time. And then you have these trackers that you put on any instrument, and then you're ready to go. So what we did for fusion is we broke it down into 3 different steps. So placing percutaneous pedicle screws, We published on this. So this was not a randomized controlled trial. However, it was a trial where I put in one screw using basic fluoroscopy, and I put the other screw using this instrument fluoroscopy navigation system. We found that we decreased the radiation, so the patient acted as their own control. We decreased the radiation by 70%. We decreased the time by 60%, okay? Now, when we were publishing this paper, one of the things that really came out to us is that we saw that there was such a difference in terms of variation. So on the left side is normal fluoroscopy, and on the right side is the instrument navigation. So all of us know sometimes it goes great. You find if you're putting a Jamshidi in, you find that starting point really well, you get going, it's really, really good. Sometimes people have overgrown facets. It's really hard to find that perfect ideal spot, right? And every time you move your instrument, you're obliged to take an x-ray, right? So how many of us are in our rooms going shot, 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 right? Now with this instrument tracking, we don't need to do that anymore because I can see as I move my instrument exactly where it's going in real time. So it decreases the variation a lot. And that's what we want with surgery. We want to decrease the variation. So you might say, well, Dr. Abd El Barr, you're fast, but are you accurate? So what we did is we took 250 screws that I put using the robot and 250 screws that I used using the instrument navigation, and they were both at 97%. So they're just as accurate. So one other thing is that most other navigation systems are instrument-centric. So when you're putting an instrument in, it puts to the instrument. This is fluoroscopy-centric. So you actually can navigate more than one instrument at one time. So that really actually now decreases the time I spend in the operating room even by half. So you can see here in this video that we're putting in 2 pedicle screws at the same time. So I just want to point out some things. So you can see where the tip of the screw is, and then each one of these points is 10 millimeters. So I can actually make the perfect trajectory, right? And this is really helpful for when you have trainees and so on, For some of us, we've put in screws for so long, we know exactly what kind of medial lateral trajectory we want. We don't have to do that anymore. So I can actually see on the screen before the fellow or the resident does anything, exactly where they are and exactly where they're gonna be. And so I can say, okay, go more medial, make your trajectory more medial, and so on. So we can do that.
Mohammed, quick question. That's very impressive, by the way. I could see how effective that would be. But on your screen to your left, where's that pedicle screw in K-wire? Is that in this space?
Yeah, so this is actually not a pedicle screw. So okay. This is getting a picture so that your tip actually is known by the fluoroscopy. So this
outside the patient?
That's outside the patient.
All right, okay.
Yeah, no problem. And so, that's how it's got to learn the tip. So you take an x-ray outside the patient, so it learns the tip, and then you can start working. So you can see here now we're working both at the same time, and I can see if I have a resident and fellow on one side, I can see exactly what they're doing at the same time. So how about interbody fusion? So as we talked about a little bit today, and I think Dr. Hofstetter for showing this, for us, there's really 3 main types of, if you're doing posterior for interbody fusion, you can do the hemilaminectomy, so on, where you're looking at the traversing nerve root. You can do the Transfacet pathway, which I think Dr. Ray really published and I've become a big fan of. And then you can do the completely percutaneous way through Cambin's triangle, which we call the percutaneous TLIF. So right now we're really being big proponents of what we call patient-specific and level-specific surgery. So everybody that comes into my clinic now gets these MRIs where we actually map out all their nerves, map out all the different pathways, and then we can tell which is the safest way. Is this going to be a transfacet TLIF? If this is going to be a percutaneous TLIF? If they need to have a direct decompression, should we do a hemilaminectomy and so on? So entering into Cambin's triangle, this is a very important thing for percutaneous TLIFs, but also for the endoscopy, and we'll touch about that at the end of the talk as well. So the way I used to go into Cambin's triangle is I used to have 2 C-arms, one in the lateral, one in the AP, right? And it used to take a lot of time to set up, about half an hour per level, right? Maybe I'm not that fast, but I was at the beginning of my learning curve, right? So there's no way you could do this case while the patient's awake, right? It's gonna take so much time. The radiation technologists don't like you, the residents don't like you. They're really pretty miserable. And then as we started developing this instrument tracking system, I realized, hey, I can see where I'm going to be in AP and lateral at the same time, and I can know where I am. So now I have decreased the amount of radiation. I only have one C-arm, and I don't have any setup time. So in fact, this data really surprised me too. This, I think, is a good paper in World Neurosurgery. We were actually able to take the time to enter into Camden's triangle faster than did when we had 2 C-arms and half an hour of setup time. So now all of a sudden, I can start thinking about doing these surgeries while the patient is awake and so on, because I'm not spending a lot of time with setup time, and it's very safe and efficient for me to get into Camden's triangle. So here's an example. This actually was from a couple years ago. So here you see a grade 2 spondy, bone on bone, very difficult case, right? I said to the resident, okay, let's put in the pedicle screws first, and then we might put some distraction on the pedicle screws, see if we can enter. We put in the pedicle screws, and sometimes I'm not so patient, so I said, let's try to do it without any distraction. So this is a non-edited video. And this is actually the older software, so the software is even better now. So here we are. So Dr. Park, we take one X-ray in the AP outside the patient, so to know where the instrument is. We go into a lateral. We take that's not a pedicle screw, that's outside the body. And now I can actually start working. So you can see here on the left, I have the C-arm in the lateral. I can say, okay, so that's 3 X-rays now. I'm getting close now, right? I'm coming in here. I feel like I'm getting into the disc. You can feel me getting into the disc. I took one more X-ray, so that's 4 X-rays. And this is not an easy case. So now the disc space is starting to open up for me, right? And I feel like I'm coming in, so I move the C-arm to an AP, just so I can take a view here and make sure then that I go, appropriately into the midline. So this case, believe it or not, was done 47 minutes skin to skin with a PGY2. How about the Transfacet TLIF? We're working very hard. I'm competing, I think, with Dr. Hartle. He's way ahead of me. I think you're right, Dr. Hofstetter. He's 15 years ahead of us. I'm just trying to learn his papers and so on. So we're looking at the Transfacet TLIF and looking at all the different pathways that we can do. So we're mapping out the nerves before we do surgery. We can kind of pick the perfect trajectory. As Dr. Hartle has shown before, we can start using, having these heads-up displays so we can know exactly where we are as we're drilling. And this is, again, another paper thing. I think it maybe comes from one of our papers. So how does that look for us in the OR? So, as Dr. Hofstetter did, when you're trying to find that perfect place to land on the facet joint, we can actually do this very nicely using this software. Not letting me pause, but I'm sorry. So I'm docked on the facet joint. I can see exactly where I'm going to be on both the AP and lateral. And look at this. When I'm putting in my trials, I can actually see where they're going, both in AP and lateral. So it decreases the amount of radiation. So now I'm not taking X-ray, X-ray, X-ray. And I'm not so nervous when there's a trainee, right? Are they going to lateral? Are they going to medial? I can actually see exactly where they're going, right, in real time. So how about lateral interbody fusions? I do a lot of lateral interbody fusions. If you look at the amount of radiation for lateral interbody fusions, it's actually about twice as much as TLIFs. And if you look at, looking at straight lateral versus prone lateral, the prone lateral decreases the amount of time because you don't have to flip. However, it doubles the amount of radiation, right? Because it's actually very awkward if you have the patient prone to have the C-arm in the lateral position, right? And that's the most important position because you don't want to be too dorsal or too ventral. So what we've done for this is we've set up a place when the surgeon is orthogonal to the disc space, we actually let them know, hey, you're orthogonal, or she know, hey, you're orthogonal. You're not going to dorsal, you're not going to ventral. That makes things so much easier. And you can see that the C-arm is actually not in the way. I can actually move it to 8 degrees, I can move it to the AP, I can move it outside the operating room if I was really confident, right? So it doesn't need to be in my way. It doesn't make my life miserable in terms of ergonomics. So this is showing us hammering in a cob here, the first initial cob. And again, I'm looking at this, what's called a ghost image. It's not more radiation, right? It's actually showing the instrument as it's moving. So I can decrease, we have data now that shows that I can decrease the amount of radiation I take with these laterals by 30%. So no, decrease by 70%. So it's only 30% of the original radiation. So how about endoscopy? I'm looking forward to next month's course on endoscopy. So if you talk to endoscopists, right, the hardest part of endoscopy is actually getting into where you're supposed to be with this targeting, right? It's a lot of places where us as spine surgeons, we're kind of uncomfortable. You ask a spine surgeon to make an incision 12 centimeters off midline, they're gonna feel uncomfortable, right? And so we've really developed this as well to do this. So we take our first dilator that we use for our endoscopy, and then I don't have to actually do all these different skin markings and so on. I can actually just tell from here, okay, on the AP, this is how many centimeters I'm going to be to get into Camden's triangle, and I can do the same thing here as well. So this is for transforaminal. So now I'm getting my dilator into the perfect position. And again, I can see if I'm going too lateral, I can change that, and I don't have to have the C-arm in my way. And a lot of people know that the C-arm gets in your way sometimes. It can get in the way of your ergonomics. It's not edited, so you can see that I'm struggling a little bit, but that's okay. But there you go. So I got into Camden's triangle with 2 X-rays, and that's not unnatural for me. So I can get into Camden's triangle. I can even have a PGY2 now do the surgery, right? Because I can see exactly where they are, both in AP and lateral, and where they're gonna be, and that's the most important part. So how about biportal? So as a neurosurgeon, I'm probably not as comfortable triangulation and so on. So we've actually brought this into our biportal techniques. This is a picture I just took out of my OR last week. So you can see here, what we did is this is the viewing channel. So we put a tracker on the trocar for your viewing endoscope, and then I have the instrument that I'm using also. So you can see here, I'm perfectly triangulated. And when you're first part of your learning curve, you spend so many X-rays just trying to learn this triangulation. All of a sudden, we've made it much, much easier. So this is a case from a while ago, I think. So we're placing the working portal. I can see exactly where it's going to be, both in the AP and lateral, so I can perfectly dock exactly where I need to be. Here we are, we're doing our hemilaminotomy here. We're taking off the flavum here. I'm starting to see the dura here. And then for some of us, this is kind of new. We're still on our learning curve, right? So I want to check, am I medial enough? Am I lateral enough? Hey, I can put an instrument in there and I can track it, both in the AP and the lateral. So it gives me more confidence, right? Hey, am I doing good enough here? I'm increasing my ipsilateral decompression now. And then I can always check, have I gone superior enough? Have I gone inferior enough? Have I gone contralateral enough? And it gives me a good check there. And again, I'm not taking X-rays, right? So it makes things much, much easier. So this is an 89-year-old lady who had neurogenic claudication. I thought she was be a good case for biportal. There's some people saying that you can't do awake biportal. We actually do awake biportal, not often, but we do it. This patient was done awake with a biportal decompression. So she had the surgery. She spent the night in the ASC. She went home the next day, and then 2 weeks later, she cooked Thanksgiving dinner for her family. And 6 months later, she's doing much better. You can't even tell where her incision is. How about cervical endoscopy? So the hardest part about cervical endoscopy, especially with people from North Carolina, they have huge shoulders, right? So it's really hard to tell where you are, especially if you're doing a lateral. Sometimes you can only see to C3. So with this technology, you can actually tell where you are both in AP and lateral very, very nicely. So here I am, I think this was a 6.7 or maybe a 7.1. I can see now with the C-arm exactly where I am without the C-arm being in my way. I have these x-rays, and then I can put the thing there and say, okay, this is where I'm gonna make my incision. And then when I'm docking, same thing. I can dock, you can see on the lateral, there's no way you're gonna be able to tell where you are. But now the C-arm is not in my way, and I can do real-time movement to pick the perfect docking spot. Other applications that we're starting to use, and SI fusion. Sometimes I collaborate with my trauma colleagues. I go into their room, and it's again, shot, 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 right? I don't want any part to do with that, right? So now this is the SI fusion I did last week. So we're gonna count how many x-rays. I took 2 x-rays to start. Now I'm gonna make my skin marking with no x-rays. I'm just gonna put my instrument there and say, okay, this is where I want my first screw to go. Everybody agree with that would be a good screw to put in there? Again, no x-rays. That's where I want my last screw to go. Again, no x-rays. And then I start working. So I can see I have 2 views here. I have the lateral view and I have the inlet view, right, at the same time. So now I can have my trainees and so on do these surgeries because I know exactly where they're gonna be in both planes, right? And all of a sudden I'm not worried. Oh, I'm so sorry. I gotta finish this video. I'm gonna show off. So here we are, we're putting that first guide pin. And again, we made this thing where when you're orthogonal, it lets the surgeon know. And then I have it now in an inlet view and an outlet view. And then again, I'm not taking x-rays. I take some spot x-rays to make sure, but I can do these surgeries and I can see exactly where I'm going the whole time. And that's a perfect surgery there. So just to conclude, I think radiation is a real threat to us as surgeons, to our patients, and to our staff, and we have to be really worried about that. I think I've really shown you different applications. For all my MIS cases, I'm using this technology. I think it makes me a safer surgeon, makes me a more efficient surgeon, and I think it makes me a better teacher as well. And with that, I'll conclude. Thank you so much.
Mohammed, that very impressive talk, and I think any surgeon who uses a lot of radiation, MIS surgeons in particular, I think would appreciate all the intricacies there with the TrackX technology. So what is involved in that? Is it based on a computer? Like, how much capital is there? I saw the tracking frames, but is it mostly software-based that you need a camera and whatnot?
Yeah, so you're gonna have a software and also a camera. It's, basic camera that we use for any of the other navigation systems. If you want to talk about economics, you probably want to talk to them. But there is a way not to have a lot of capital cost. It's much less expensive than a robot or anything else.
Mohammed, I really enjoyed your talk, and I think you're filling that gap, below technology, where we want to be very nimble and do these cases. So I want to applaud you to identifying that spot, because I think there's obviously room for navigation and robotics for the more complex, more than, what would be more than 5-6 screws? You're probably better off if using a more sophisticated. But most of our pathology is 1 segment, 2 segments. So I think that's terrific. Now my real question is, why did you not do a transferamal on the 93-year-old? A transferamal decompression on the 93-year-old.
Why I did or didn't?
Did not. So you did an interlaminar decompression, right?
Yeah, she had bilateral symptoms, so that's why I did that.
Okay, so you did that. So how does it, in your endoscopic cases, where do you find it the most helpful?
I think for the transferaminal, it's so helpful, right? Because as you know, getting into that perfect place is very difficult. And there's really not much room for error, right? And if you have the C-arm only in one dimension, right, you'd really have no idea where the resident is both, in the AP. So if you put it in the lateral, right, you don't know if they're too medial, you don't know if they're too lateral, right? And this really helps with that. I think when the transforaminal really shines through.
And how much motion of the patient do you see? Is the patient very static there? Because, I mean, that system really assumes that the patient doesn't move in between. Do you follow that somehow, or is that really that you're just, whenever you kind of periodically re-image?
This is a great question. So there are two ways to do it. You can do it without any type of fixation. And that, I do that for most of my transforaminal cases and so on. But let's say for prone lateral, there's a lot of movement and so on. There is a way to actually fixate something on the PSIS and have that kind of be as a reference point.
Great.